Go ahead, Kelda.
Okay. Hello and welcome. The Alaska Mental Health Trust Authority appreciates you attending the third and final session of our Alaska Medicaid Block Grant Information Sessions. The topic today is key considerations for negotiating terms and conditions. We want to show our great appreciation to both Dennis Smith and Andy Schneider for guiding us through this topic, and for Steve Lutsky from HCBS Strategies for coordinating the sessions. Thank you for joining us today.
Okay, welcome to everybody. You should be seeing my screen now. In terms of the sessions, the purpose is just to be educating the trust staff and the stakeholders about the opportunities and challenges of a Medicaid block grant. Well, the first session was just kind of a 101 on block grants and some of the histories and so forth. The second session focused on the budget side of things and the parameters for negotiating a budget. And this session is focusing on the terms and conditions, what could be allowable under an 1115 block grant that would not be allowable under the regular Medicaid program. Okay, and we're using the same format as we did for the other sessions, that we're anticipating a presentation of roughly around a half an hour. The rest of the time will be reserved for questions and answers. You can enter questions using the Q&A button, and you can enter those at any time, but we won't be answering the questions until after we've reviewed the slides. If a question has already been answered, or if you think it's important, you can use the upvote button, which looks like this. It's a little bit subtle on there, but if you click that next to it, we'll see how many people have identified this as an important question. You can also clarify or expand upon an existing question by commenting on that. And then we're also going to open up so that people who are at the trust will be able to ask their questions directly. Now, when we review the questions, we're going to try and group similar ones, but we're going to focus on the questions that have the most upvotes. Once it's we believe it's been answered in the conversation, we're going to mark it as being answered. If you get a notice that your question was addressed, but you don't think that it was answered, please ask the question again, possibly rephrasing it. You can only speak if you're using your computer or microphone, and the host turns the microphone on. We may not get to every question, but however, in the last two sessions, we did manage to get to all of the questions. We want to acknowledge one thing in that we're aware that the Public Consulting Group report came out, and this is a copy of the report that many of you may have seen. The panelists are familiar with it. They've looked at it. Their presentation will not address it specifically, but they are willing to answer any questions that you have about components of it. And I'm going to, for those of you who, if there's anybody who's desperately trying to find it, I'm pasting a URL to it into the chat function, into the chat window. That said, I'm going to reintroduce our speakers. First, we have Andy Schneider, who is a research professor at Georgetown University McCourt School of Public Health. He has over 40 years of experience with the Medicaid program, working as a congressional staffer, an executive branch employee, a private consultant, and a public interest attorney. He was a senior advisor at the Center for Medicaid and CHIP Services under the Obama administration. That is the center that oversees all of Medicaid, and he led the development of the Medicaid resource book for the Kaiser Commission on Medicaid and the Uninsured. Our other speaker is Dennis Smith, who is currently a senior advisor for Medicare and healthcare reform at the Arkansas Department of Human Services, and also a visiting professor at the University of Arkansas Medical Sciences College of Public Health. He has worked for many states, Arkansas, Wisconsin, Virginia, and California. He also, like Andy, had some shared experiences. He was on Capitol Hill for about 10 years, and he actually headed CMCS for 7 years. And that's the longest tenure that anybody has had that position as the federal Medicaid director. In that role, he negotiated Section 1115 demonstration projects in more than half the states. And with that, I'm going to turn it over to Andy.
Good morning, everyone. And we're going to try to follow the same format that we've done in the previous two. I'm going to give an initial overview of each slide. Dennis is going to comment on my presentation, and hopefully we'll be able to move through these expeditiously, so there'll be plenty of time for questions. So let's start with the authorities that the Secretary has. This is the Secretary of Health and Human Services under Section 1115 of the Social Security Act. And this, as you'll quickly come to see, is highly relevant to the questions that this webinar has been addressing and that you all are focused on. So, normally when people talk about Section 1115, they use the term 1115 waivers, sometimes 1115 demonstrations. But waivers, the waiver authority is only one of two pieces of the 1115 authority. The statute actually gives the Secretary two distinct authorities. One is to waive certain requirements of the Medicaid program found in Section 1902 of the Medicaid statute. That's known as the waiver authority. The other is an expenditure authority, and that lets the Secretary make federal payments for expenditures that are not normally allowed under the Medicaid program. And these, of course, as with everything in Medicaid, there's an acronym, CNOM, costs not otherwise matchable. These are spending on populations or on services or both that would not, under normal Medicaid rules, be matchable by the federal government. I'll give you an example of this. You in Alaska have a waiver involving substance use disorder and behavioral health programs that was approved last November. And it took effect on January 1st, and it's good through December 31st, 2023. There are both waivers and new expenditure authority in that 1115 demonstration. One of the waivers, for example, is statewide-ness. You are allowed to implement this substance use disorder demonstration only in certain parts of the state initially, and then broaden it to other parts of the state. That normally would not be allowed under regular Medicaid rules. Similarly, in terms of cost not otherwise matchable, you're allowed to cover, for among other things, residential treatment services for individuals with substance use disorder. And this is for individuals receiving treatment and withdrawal management in facilities that are, in the statutory jargon, known as institutions for mental diseases. Normally, for adults between 21 and 65, residents of IMDs, or residential treatment facilities, would not be eligible for federal matching payments on the cost of their services. In the context of this demonstration, that's a cost not otherwise matchable, and federal dollars are being made available to the state to test out how effectively that is used in reducing overdoses, improving treatment, et cetera. So, Dennis, you have anything to add on that?
Just to add real quickly, again, CNOM is one of those areas, again, that the Secretary, remember, has complete discretion over. So CNOM has, just because the Secretary may grant matching funds to one state for one particular initiative, doesn't necessarily mean the Secretary will continue to do that for any state, and every state that wants to go through that door. Again, where their previous administration granted a number of waivers to provide funding in hospitals, for example, the DSRIP program that may have heard about. The new secretary, the new administrator of CMS has no obligation to extend those to additional states or to continue them. So again, the discretion of the secretary is very important to keep in mind through all of this.
Right, point well taken. So Steve, I think I need the next slide.
Okay, it should be up.
Yep, okay, got it. All right, so so now we're going to have a couple of slides that go to the question of the waiver authority, not CNOM, but the waiver authority. Let's just start with the basic concept that if a state participates in Medicaid, there are certain populations that it has to cover and other populations that it may cover. There are certain services that it has to cover and other populations and other services that it may cover. So that there's a link there to something that the Medicaid and CHIP Payment and Access Commission, MACPAC, which is a congressional agency, has put together that summarizes all of this information. I don't want to take the time to do this now, but just so you understand the concept, the context in which the word mandatory is being used here, it's only if a state chooses to participate in Medicaid. All states have done that. I expect that will continue. And to that extent, coverage of certain populations, coverage of certain services is mandatory. If you want, as a state, want to let the federal government cap its matching payments for the services and the beneficiaries you're covering, you need to figure out some way to limit the number of people who you cover and the services that you cover and what you pay for those services. So we're going to walk through some of these things that you would need to waive in order to protect yourself from having to spend more money than the federal government will match under a block grant. Because again, a block grant is just a fixed amount of federal dollars over a certain period of time, and you are at risk as a state for everything you spend above that amount. So beneficiary protections. The classic way that a state would approach living underneath a cap on federal matching funds is to cap enrollment. So, of course, states don't have to cover optional populations, but they do have to cover mandatory ones. And mandatory populations, for example, would include kids up to age 18 with in families with incomes below 133% of the poverty level, or pregnant women at that same income level, or parents of dependent children, and there the level would vary from state to state. And I can get that level. I do have that level for Alaska. I just don't have it handy in front of me. But so there are some mandatory populations. In order to limit your financial exposure as a state for paying for those populations, you would want to be able to cap enrollment when you decided you'd spend enough as a state and you were running up against the federal budget limit. So the first problem you encounter is that the Medicaid requires that if someone applies, that their eligibility be determined with reasonable promptness. That's in 1902A8. And again, Section 1902 is a section that the Secretary does have the authority to waive. What reasonable promptness means in terms of the regulations is if you're not applying on the basis of disability, the state has to make an eligibility determination within 45 days of application. If you are applying on the basis of disability, the state has to make a determination within 90 days. It can't just sit on your application for a year or 2 or 3. So that's an example of something that would have to be waived. Along with that, to the extent that a state doesn't want to cover a particular mandatory population, whether it's kids, pregnant women, parents, individuals with disabilities who are receiving supplemental security income or SSI payments, could march down the list of mandatory programs. Waiving the requirement to cover those would be part and parcel of this as well, and the state would have to choose who it wanted to cover and who it didn't. Similarly, with comparability, that's a technical Medicaid term. It means within a particular eligibility group, say kids, I'll just use kids because I'm at the Center for Children and Families, but this would apply to any population. All children are entitled under Medicaid, who are eligible for Medicaid, they're all entitled to a pediatric benefit called Early and Periodic Screening, Diagnostic, and Treatment Services. And a state under regular Medicaid rules can't pick and choose among children as to which get EPSDT services and which don't. That's the comparability protection. Again, if you're looking at a federal funding cap, as a state, one of the things you would consider is extricating yourself from that requirement. And again, as with everything we'll discuss here, there's an underlying legal issue, and that is whether the waiver would be, quote, likely to promote the objectives of the Medicaid program. And that is the test that the Secretary would have to apply in deciding whether to waive any of these particular requirements we're talking about, and that is the test that the courts apply in reviewing the Secretary's decision. Dennis?
Yeah, if I could add just briefly, in general, I think we are talking about populations that are in the optional category. In all of the waivers that have been approved, I cannot think of a single one that affected the eligibility of a mandatory population. So I think in general, we are talking about the optional populations.
Okay, Steve, I think we can go to the next screen.
Okay, it should be up.
There we go. Okay, I guess I'm on a delay. Sorry. So, of course, one of the cost drivers in any Medicaid program is what kind of providers are delivering the services that you're covering to the beneficiaries that you're covering as a state, and what you're paying those providers. So there are a couple of relevant requirements in the current Medicaid program that a state would want to consider asking for a waiver of. One of these would be what's called the freedom of choice of provider. That allows any qualified provider to participate in Medicaid fee for service, and that's what's relevant in Alaska. Providers are not required to participate, but if they want to, and they're qualified, under state licensure law, and they are not have not been excluded from, say, the Medicare program for fraud against the Medicare program. In other words, they're qualified, then a provider could participate. And that's true whether the provider's high cost or low cost, efficient, inefficient, wouldn't matter as long as they're qualified. So if the state wanted to limit what providers were delivering services to maybe target just the low-cost providers, or encourage providers to become low-cost in order to qualify to participate, they would have to seek a waiver of this. There is a requirement that states make disproportionate share payments to certain hospitals that serve disproportionate numbers of uninsured and low-income patients. Check the figures for Alaska. You're spending very little money on on DISH in relation to your total program spending. So I'm not sure how relevant this is, but it would be something that the state might want to consider doing. There is a requirement in the Medicaid statute that federally qualified health centers, rural health clinics be paid using a particular methodology that ends up, it's called prospective payment system, PPS. It ends up paying them approximately their cost per visit. And a number of states have expressed concern about that formula, and they find it too expensive. So that would be another area where a state might want to look to obtain a waiver and reduce its financial exposure. And then finally, there's this broad, far more nebulous standard called the Equal Access Payment Standard. And that applies to, again, all fee-for-service states and providers in a fee-for-service state. And it basically requires that a state have payment levels for services that are sufficient to enlist enough providers in the area that Medicaid beneficiaries have roughly the same access to those provider services as other individuals. And there's been a lot of back and forth between the federal government, the states, the providers, and the courts over this. And where it currently stands is that the Center for Medicaid CHIP Services is now proposing to repeal the regulations that implement this equal access requirement. So depending on how that comes out, it might not be necessary to waive it, but it would be something that if you were looking for flexibility on the payment side as a state, you'd want to consider asking for a waiver of. And again, the legal test would be the same. Is it likely to promote the objectives of the Medicaid program? Go ahead.
If I could just add, if I could add just a brief note. Again, this is an area that quite a number of states have received waivers in these areas. Freedom of choice perhaps is the most common waiver of all because of the movement to managed care, et cetera. So these are areas that are very familiar and have been waived. The equal access and to some extent the freedom of choice in some states actually is more of a state issue rather than a federal issue. Arkansas, for example, has a very strong any willing provider protection in the Medicaid program, even stronger than what is at the federal level. So again, you all often have to keep in mind that these are waiving federal statutes, statutory provisions, but you've also, if there are ways that you can, ways that you are going to have to accommodate state laws may be just as important and in some cases even more important than federal.
That's an excellent point, Dennis. I didn't know about that about Arkansas. Very interesting. Okay, this is less relevant to Alaska unless you decide at some point down the road to go toward a managed care delivery system rather than fee-for-service, but there is a requirement that managed care plan payment rates be actuarially sound so that the payment levels going to plans are going to be sufficient to allow them, if they're efficiently operated, to deliver the services that they're contracting to provide to the people who are enrolling in the plans. And again, that would be something that the state would want to explore. The little problem is that that particular requirement is in Section 1903, and again, my own view is that's not waivable by the Secretary under Section 1115. The other point here on this slide, I seem to have lost the slide on the screen, but so tribal facilities and IHS facilities have a right to participate in state Medicaid programs. That's found in a different section of the Medicaid statute. It's found in Section 1911. Again, that couldn't be waived if the state were trying to consider that. Dennis, any thoughts on this?
Just briefly, and just kind of a sidebar on capitation rates and actuarial soundness. Again, this is an area that has continued to evolve over the years, and the role that CMS plays in its review of actuarially sound rates has become much more hands-on and intensive than in recent past history. So again, the importance of hiring a good actuary, one that has a lot of experience in state programs, if you go down that route, and that quite frankly, a few states I think have opened themselves up to criticism in paying rates that are too high for the expansion population, because at first the federal government was paying 100% of the rates. That goes what is it, 93% this year, I think. But even so, in that expansion population, because the federal government is paying such a greater percentage of the cost, they have become much more involved in rate setting.
Good point. So we've been talking about the kind of flexibility a state would look for if it were going to go down the block grant road. There are a couple of other considerations than just capping enrollment or excluding high-cost providers or reducing payments to high-cost providers. A state might also want to target high-cost benefits or high-cost beneficiaries, because again, the idea here is if you're limiting the amount that the federal government is going to match to a fixed sum, you have to, your first order of business is to find all the high-cost areas in the program and figure out some way to reduce them or eliminate them. On the high-cost benefits, the kinds of current protections in the statute that you would have to address, you would reduce, for example, the list of mandatory services. There's a discrete list in the statute, and you'd have to go into those and, for example, say, we don't want to cover FQHCs anymore. I'm personally not recommending that, but as an example, that would be one relative to other ambulatory care providers, that would be a high-cost service. There are requirements in the statute that if you offer a benefit like inpatient hospital care or outpatient hospital services, that the benefit be sufficient to reasonably achieve its purpose. And there's some squishiness around that standard, but the idea is, offering an inpatient hospital benefit that covers you for one day a year, that's not sufficient. If you wanted to start squeezing down on benefits as a state, that you would have to eliminate that sufficiency of benefit requirement. In terms of drugs, You know, we're all familiar with the pricing practices that have gone on over the last couple of years on the part of some manufacturers for some drugs, and they are too high. And how to manage those high launch prices and high annual rates of increase is a subject of considerable discussion right now on the Hill, and some thinking in the agency. But one thing the state might want to consider while awaiting the outcome of that, if you're going to limit the federal government's participation in your program, you might want to look for some ways to avoid having to cover high-cost drugs, period. That could be a whole webinar in and of itself. I'll just leave it at that as an example. Again, I'm not personally recommending it. You could also target high-cost beneficiaries. There are restrictions on which types of beneficiaries a state can impose premiums on, the amount of the premiums in relation to the beneficiary's income. You could look into waiving some of those beneficiary protections. Same thing with deductibles and co-payments. And of course, the upshot of that would be, in the case of premiums, a lot of people would not make the premiums, and you would have reductions in enrollment and increases in uninsured. On the deductible and co-payment side, in a lot of cases, this is just it's the same as a reduction in payments to the providers by the amount of the deductible or co-payment, because at some of these income levels, people simply can't afford the deductibles and co-payments, which is why the statute currently protects them against them. There's been a lot of national conversation about community engagement requirements. I don't understand that to be a current topic in Alaska. Correct me if I'm wrong. But some of the states that have tried to impose work requirements, community engagement requirements, have gotten approvals for that from the Center for Medicaid and CHIP Services, and have found themselves in federal court. And as things now stand, the district court judge has stopped 3 states from going forward with this: New Hampshire and Kentucky and why am I blanking on the other? Arkansas. Sorry. Yeah. Arkansas and Kentucky and New Hampshire, and that's on appeal. It'll be argued in October. We'll probably have a decision by the end of the year, and it'll be clear what the path forward on that is, if any. And the final thing that the state might want to look at is changing the rules about family responsibility. These have been around for a long time. Nobody is really talking about them in any significant way right now, but just understand that in Medicaid currently, sons and daughters are not responsible for the costs of long-term care services for their parents in a nursing home or in home and community-based services. And that's because federal law does not allow states to go after the sons or daughters of low-income parents who need long-term services and supports. That could be waived. So again, it could be waived if the Secretary finds it's likely to promote the objectives of the Medicaid program and if the federal courts agree.
If I could add just a little bit, and Andy's point that we could have an entire series of webinars just in the area of benefits, for example, and what the different combinations and permutations. In that you go beyond talking about just the benefit itself into the amount, duration, and scope of that benefit. So yes, I'm covering inpatient hospitalization, but I'll cover the Medicaid program will cover it up to, let's just say arbitrarily, 10 days. So what happens after, the 11th day and beyond? How much can be done by limiting the benefit based on prior authorization to say we will prior authorize 15 occupational therapies. And if you need more than that, then you have to come back and get an extension of benefit. So again, you have, you know, in many respects, these insurance concepts within Medicaid that states may vary widely in how they use amount, duration, and scope, and prior authorization and utilization management tools.
Okay, so the next slide is just to make the point that both Dennis and I have been making for the last two webinars, that at least under Section 1115, the Secretary doesn't have the authority to change the requirement that the state has to pay its share of the cost of covered Medicaid services for eligible people. So right now, the state share for most populations and most services in Alaska is 50%. For the Medicaid expansion population, the newly eligible adults, it's 93% this year, 90% next year. But those, that feature of the program, those features of the program specific to Alaska, the general formula, and the concept that the state spends money and the federal government matches it, that can't be waived.
I agree.
Okay, and then the last question was, and I think we addressed this in part in one of the previous webinars, was can the state withdraw from a Section 1115 demonstration? And the answer is yes. And it can do that at any time. It doesn't happen often, but it could be done. Maine recently did it with respect to its community engagement waiver. It had been approved, but it didn't accept the approval, and so it's not going forward with that. The standard terms and conditions, the special terms and conditions that are negotiated between the state and CMS are where you find the rules about withdrawing. There's a provision like that in the 1115 substance use disorder and behavioral health waiver that Alaska now has. And the short of it is there are some spending targets in that waiver for those services because there are some costs not otherwise matchable involved there. If those get exceeded, then the excess has to be paid back to the federal government. So throughout the waiver, the budget neutrality requirements continue to apply. If the state wants to drop out in year 3 of a 5-year waiver, you'd look at the budget neutrality over that 3-year period. But that doesn't stop the state from withdrawing. It's just reconciling whatever the state has spent beyond what it's allowed to spend under the budget neutrality terms and conditions that are set forth in the approval.
So just to give you a couple of examples on the STCs that states really spend most of the waiver preparation time working with CMS on. The original waiver, the Arkansas received approval from December 31st, 2014. There were 91 specific special terms and conditions. Everything that from auto assignment of members to disenrollments to memorandum of understanding to quarter evaluation reports, operation reports, et cetera. So there were 91 separate STCs. And then when the waiver for Arkansas amended the waiver March of last year for the community work engagement, there were another 90 specific STCs, including monitoring calls, performance metrics, public access, et cetera. So again, these are these are very detailed. Every word counts. Every word literally is negotiated between the state and CMS.
Truer words were never said.
Okay, so we're at the end of the slideshow. Right now we have a couple of questions. One's really just a comment that the administration in Alaska is evaluating the work requirements, and legislation has been introduced but not passed in Alaska. The second one is that, and this, Dennis, will be especially relevant for you. Community engagement requirements are in fact an issue in Alaska, but bills directing our agency to apply for an 1115 waiver have not yet made it through the legislature, and the public consulting group proof of concept paper is ambiguous, ambivalent on whether pursuing work requirements at the same time as pursuing a private option would be feasible. I know that Arkansas is trying to do both, but was that at different times, the private option in 2013 or so and work requirements in 2017 or so?
Yeah, the original waiver, and the one that I just spoke about, had the private option in it. And by private option, what is meant is that because these are still Medicaid dollars are used to purchase coverage through qualified health plans. So the Medicaid dollars are actually going to 3 different carriers here. These are private entities. These are not Medicaid managed care entities. They are commercial products regulated by the Arkansas Insurance Department. So the private option is Medicaid dollars purchasing coverage through the QHPs. The QHPs are negotiating directly with providers, and generally those are much closer to commercial rates than Medicaid rates. The work and community requirements, engagement requirements, let me back up a second. So that original waiver was approved on September 27th, 2013, and it was good through December 31st, 2016. So as the Governor Hutchinson took office and brought his team in, there was an amendment. I'm sorry, the waiver was coming up for renewal, so we still built upon the previous waiver, but then got approval for another 5-year renewal. And then in 2017 submitted, so that approval was done by the Obama administration. So that approval was took place at the very near end of the Obama administration. Then in 2017, Arkansas submitted a waiver amendment. So the underlying waiver was still there. The work and community engagement provisions were amendments to that waiver. In the 2016 approval, again approved by the Obama administration, Arkansas was approved to do what was called a work referral. So the newly eligible population was referred to a sister agency, the Department of Workforce Services, for people to, we referred them to DWS for training, for educational programs, for them to help individuals seek and find employment. However, that was only a referral. There were no consequences for individuals if they did not do anything subsequent with, if they didn't go to DWS, there was no sanction, there was no penalty. If they did not avail themselves of any of the services, there were no sanction or penalty. So when the 2017 amendment came along, we had a much more detailed approach, and I won't go into, it's a very lengthy discussion about the details, but there were specific sanctions for failure to comply with those. That is what has been put on hold through litigation. So we, we cannot and are not implementing in any way, shape, or form anything that we've been enjoined from. However, the underlying waiver of work referral is still there, and so we are still referring people. But as I said, there are no consequences to not avail yourself of those services.
Great. So just to be clear, that for Alaska's case, it should theoretically be possible for them to pursue at 1115 that includes both the private option and the work requirement / community engagement components.
Yes, in terms of writing your waiver, there you can pursue both at the same time. There is another provision actually that when we submitted the work and community engagement amendment, we also had an amendment in that package that would have allowed us to lower the newly eligible population from 138% to 100%. The administration did not approve that. Technically, it is still sitting at CMS. So there is, it really is up to the state how they want to, how the state wants to package any number of provisions, either that you want waived or that you are seeking CNAM. So it really is up to the state to decide that package, what they want to look like. Also, we had within that waiver a reduction in retroactive eligibility, for example. So you can put an entire package together at your will.
Okay, great.
Yeah, you can put the package together. Just consider your litigation risk.
Okay, we've had a few more questions that have been coming in. So the next one, Dennis they identify you as the person to answer it, and asking if you can elaborate on how AI/ANs are handled in the Arkansas private option. Do ARRA protections apply, cost sharing exceptions, payment rates for I/T/U providers, etc.? And do QHP protections in the Affordable Care Act apply? Monthly enrollment options, no cost sharing with PRC referrals, and its tribal sponsorship allowed. Finally, were there state consultation requirements to set the program up? And I know there are not tribes in Arkansas, but are there I/T/U beneficiaries present?
Yes, there are, and the questioner was correct. We don't have recognized tribes, but we do have individuals, and basically they have a choice of how they want to participate. Is the short version on that. So yes, there were. Because we didn't have tribes here in Arkansas, our notices to the general public, individuals were encouraged to participate in that way. We did have a very public, very openly public process for doing all of this. And, you know, obviously Alaska has a very unique set of circumstances. And also the opportunities, because you do have tribal organizations delivering care directly, and that is something I think the state and the tribes should talk about in how to use the service delivery platform that's available there. Did I catch all of the points, or did I miss a couple?
The one that you missed was the one, the ARA, I'm assuming that's the American Recovery and Reinvestment Act, those provisions and whether those still applied on the payment rates and other protections.
Yeah, the additional match rate for primary care, is that?
Yeah, and there was also the maintenance of effort requirement and so forth. But I think
that's,
yeah.
Well,
this would have
yeah, the payment expired, and the state did not put up additional state funding to return to those higher provider rates. The MOE protections, again, Arkansas was a very low federal poverty level, so our previous TANF population was down to 16% FPL. So the MOE requirement did not really have much of an impact in Arkansas because of those low rates, and we were required to maintain those rates.
Okay. I'm just looking through the question, and Jim, I'm going to unmute your microphone if there's anything else that you want to ask and follow up on that.
Yeah, I just unmuted. Can you hear me okay?
Yep.
Yeah, let me try asking the question another way for Mr. Smith. And certainly if Andy is, wants to pipe in, that's fine too. But I'd be interested to hear, ARA prohibits cost sharing from being charged to American Indians and Alaska Natives. So if you have a private option and an individual goes into the insurance exchange and a premium's required to sign up for that plan for coverage, do those cost sharing exemptions apply? And if they do, to what extent do they apply? Are they a categoric or carte blanche 100% exemption, or would the QHP cost sharing exemptions that are present in the ACA for American Indians and Alaska Natives apply? So the two policies are both very important and very different at the same time. Thank you.
Yeah, thanks for the question. And now that you asked it directly, I'm not certain of the answer. I'd have to go back to check with our general counsel to see how those cost sharing provisions are applied. I shouldn't say.
I appreciate it. Sure. Yeah, it's a level of detail that I know you didn't expect to get into the call, but yet I think it's a very important element that would need to be known in Alaska if this process was to move forward. Thanks.
Yeah, I'll be happy to check, and I'll get back to Steve on the answer.
Okay. Great. Okay. We have a question also for you, Dennis, about how many individuals have lost coverage in Arkansas to date following the implementation of work requirements?
Let me state it this way, in that we know about 18,000 people, I should say there were about 18,000 fewer people in the newly eligible category. However, because we were stopped by the district court, we also stopped our evaluation. So that the individuals, our reduction in the rolls could be attributed to a number of different areas. Including, we have a very strong economy. Individuals could have gained employment, gained coverage, left on their own. They could have also, they may have left for reasons of non-compliance, but we don't know why. They chose not to. We do know that we had a very extensive outreach effort. We contracted with a vendor here in the state that conducted about 300,000 points of outreach in terms of multiple phone calls, emails, letters to the best known address, etc. We also know about 5,000 individuals have come back onto the Medicaid roll because, again, at January 1, all of those individuals could have applied for Medicaid again, and if they were otherwise eligible, they would have enrolled. So again, I think it is more precisely understood that these are individuals who may still be eligible but unenrolled. Obviously, 5,000 have come back. That may be, we would. Again, I think everybody missed a very important opportunity to start to have sufficient time to do a proper evaluation and to understand why people left, why some came back, and why some have not come back. Part of our evaluation that we were designing was the CDC does a national health insurance survey every year that includes people who are on who have health insurance coverage, and it includes people who do not have health insurance coverage. There are multiple questions about health status, about whether someone has a usual place of care, whether or not someone did not seek care because they couldn't afford it, etc. That survey would have been part of our evaluation. So again, there's still a great deal we would like to know about this population. And again, I think to some extent, we have unanswered questions as well, and we would very much like to know how this the impact of this on individuals. But again, those who left because of, as I said, people left, but for several different reasons. So it would be a mistake to say they all left only because of the work requirement. I don't think that would be a true statement. Why some have come back and some haven't, we would very much like to know that. And again, here it is, August. It's, the 18,000 who left, as I said, about 5,000 have returned. The other 13,000 could apply today, and if they were otherwise eligible, would be re-enrolled. So, again, I think this is an area that still very much needs to be evaluated, so we all have good, solid evidence as to why people, what may have motivated one person. As I said, the work referral was not very effective. So do you say, well, look, when someone was required to, then they did increase their participation, they increased earnings, etc. We should want to know. We should want to know why, and so let me leave it at that.
Okay. So we got another question that again is somewhat complicated, so I'm putting it up here on here just so that you and Andy can actually see it at the same time. So within the existing Alaska Medicaid program, can every single Medicaid eligible recipient, including mandatorily covered individuals of all ages, be mandatorily enrolled in a managed care / restricted provider program? In other words, could family members be made responsible for the costs of care through this mandatory enrollment in a managed care program for individuals under age 18, or would the 1902 A17D not allow for that? Would this type of restriction and cost sharing be through some sort of 1115 waiver that was created in a way that it applied to all individuals in the Alaska Medicaid program?
So let me start with that, and then Dennis can jump in. I think there are two issues going here. Let's try to separate them. On the family responsibility, yes, A17D would prohibit making a parent financially responsible for the child, or a parent financially responsible for his or her parent. And that has nothing to do with managed care. That's just across the board, fee-for-service, managed care, or some combination thereof. So that's one thing. On the managed care issue, Alaska has, right now, as I understand it, a fee-for-service delivery system. If it wants to change that delivery system to managed care for some or all of its populations, it has options to do that. There are state plan amendment options and there are waiver options to do that. But right now it can't. It would need the approval of the federal government, which is available to go down the managed care path for some or all of its populations. I'm sorry, I have to confess, I just don't understand the last question. Can the 1115 waivers be used to change cost sharing protections? Well, yes, on paper, the cost sharing protections are in section 1902, and so they could be, to some extent, waived. This gets real complicated very fast because, of course, there are some cost sharing that even 1115 can't touch due to a separate provision in Medicaid. So I guess I'd like to say to that, it's just too complicated to answer here. My general inclination would be no, but
in Medicaid, it's always a little slippery to use words like every and all, because every and all almost never applies because there's so many different population groups. There are just as we had the discussion previously on cost sharing for Native Americans, there are so many exceptions that you have to work your way around.
If somebody wants to clarify a point on this question, please raise your hand by clicking that button at the bottom and I will unmute you. Okay. So I was going to see if there's any questions in the room where Kelda is. Okay. Kelda, you're muted right now. I will unmute you. Because I wonder if we're trying to. No, you're unmuted now. Nope, now you're muted. Okay. Oh, well, Kelda just texted or chatted saying that they have no questions in the room. Okay, we'll leave it open for just 1 more minute to see if there is any other questions. Don't see any that are coming on. Andy or Dennis, do you want to make any closing remarks?
Well, I just thank you to people for hanging in there for these 3 sessions. I hope they've been useful. Yeah, no other points. And thank you to the Trust for holding the webinar and promoting an understanding of Medicaid generally and why block grants are such a bad idea in particular.
Well, I was going to associate myself with the comments except for that very last one.
I thought you'd like that one.
But thank you so much for including me. I enjoyed it, and getting to work with the folks on this, and really appreciate Andy's work. He did the great bulk of this work in preparing the slides, and really appreciate it. And thanks to Steve as well.
Great.
And the rest.
And we've received a lot of feedback about this. The overwhelming feedback has been that people have really appreciated the collegial manner in which you guys have approached each other, that you're speaking to your different views and representing them very well, but the way that you have done it in the respectful manner and the manner in which you are listening to each other has been very much appreciated. I have really greatly appreciated it, and I want to thank both of you for participating and for engaging in the dialogue in this way. So thanks to all.
Thank you.
We'll be closing it out. Thanks, and everybody have a good rest of your day.